Hi, Amanda. Welcome to the March SWFT Board. Delighted to see so many members of the public with us, and delighted that we start the meeting as ever with the Going the Extra Mile Award winners. So I'll do them in the order they've been given to me, but the first Going the Extra Mile Award winner is Emma, who's a nursery nurse. So this is your commendation, Emma.
Thanks.
The second Autumn 2021 Clinical General Award winner is Emma, nursery nurse in the Special Care Baby Unit, after a member of staff nominated her for being passionate about improving care for babies and their families, and how she is always looking at ways to make it better. Emma also worked tirelessly to achieve the Bliss Baby Charter Award, Silver Award. The nominator also said that Emma always pulls the team together. So Emma, congratulations, absolutely delighted for you. And what you do is such an important area of work. But round of applause for Emma as the first of our Going the Extra Mile Award clinical winners. So thank you, Emma.
Thank you.
And then up is Tracy, and Tracy is one of our specialist palliative care nurses. And she was nominated after a member of staff nominated her for being extremely compassionate and supportive to many families who have said they simply couldn't manage without her. The nominator said Tracy is a source of inspiration and support for her colleagues, and went out of her way during lockdown to keep her team positive and reminded them that they were valued. They also said that Tracy is a truly remarkable nurse who's touched the lives of many, many people over the course of her working life as a Macmillan specialist palliative care nurse, and that Tracy is the driving force behind the palliative care team. Tracy has now left the trust, working for Macmillan entirely. However, we felt it important to recognise the impact she's made on so many patients over so many years. So Tracy, a big, big round of applause and enormous thanks for everything you've done. I can't see you, but I assume I can see your initials, but I can't see your face. But thank you very much, Lisa.
No, and thank you very much. I've thoroughly enjoyed working for the Trust, and you know, I was just stuck for words and thank you for acknowledging me, even though I've just recently left, and just carry on with all your good work. Thank you so much.
Yeah, I mean, what you do, Tracy, and everyone we're talking about, and we'll go on to the bereavement care team in a second with the midwifery, the work you do is incredibly important, and Tracy, you're an inspiration. Thank you.
Thank you.
So our team winner is to the maternity bereavement team. The team were chosen after they received a nomination for always providing a very personalised and caring service, even when they are working in some of the most stressful areas of maternity. A patient emailed to say that in her darkest of days, they treated her and her family in the most tender, kind and thoughtful way, and they could not be more thankful. The patient described them all as walking angels. And team, I can't think of a nicer commendation. And, you know, I often say to colleagues, the most important thing arguably we do as a trust is bringing life into the world and being appropriate when life leaves the world. And, you know, Amanda, Maria, Rebecca, the stuff you do, I'm in awe of. So thank you so much on behalf of the Trust, on behalf of all of the families you look after, and on behalf of the mums and dads. Thank you. You're stars. So you're very welcome to stay for the rest of this board session, which goes on a couple of hours. And I would understand that with enthusiasm in your heart, you would choose to do that over your normal working day. Equally, I would understand if you need to disappear and don't go and do the other important stuff that I know you do. But thank you, guys. Really proud of you all, and take care of yourself and take care of your colleagues and take care of our patients and their loved ones. Thank you.
Thank you.
Yeah. Bye-bye.
So we have apologies of absence from Fiona. So I think Fiona's quite wisely sunning herself on the west coast of Africa somewhere. But delighted that Rebecca's joining us to look after us as well. So thank you for doing that. Any new declarations of interest? Please raise a digital hand if you've got any new declarations of interest. Can't see any declarations of interest. Last set of minutes of the meeting held on the 2nd of February. If you want to make any amends for accuracy, please raise a digital hand. Okay, can't see any digital hands raised, so I'll take those as accurate and I'll duly sign them. So I think we had a couple of action points arising. The first was the appointment of the Vice Chair. So Simon, thank you very much for taking up that important role. Then recommendation for Senior Independent Director. And Sue, thank you for taking that on board. Sue's got the onerous task of running the appraisal process for me every year. So good luck with that one. Then we talked about the Green Plan, and we said that Sophie would bring back the options on the Green Plan to the board on a regular basis. Sophie, when do you think we'll see you again on that?
So I'm meeting the next sustainability strategy meeting is coming up in the next few weeks. So we were going to agree there all the reporting lines. So if I could bring that back, Russell, that'd be great. Okay, great. Thank you, Sophie. And then Glenn, regarding the Managing Director of Innovate, be invited to a future board workshop to review the smart technology. When do you think that might happen, Glenn?
Not entirely sure, Chairman, but it will happen soon. Thank you for that specificity, Chief Executive. We look forward to the detail being put in the action point log soon. Any matters arising that I've missed? Okay, colleagues, happy to move on. So the first is just to formally ratify Sue's appointment as Senior Independent Director. Everyone is briefed on this, and the paper speaks for itself. I do want it for your approval. So if you're not happy to approve Sue as Senior Independent Director, please raise a digital hand. Sue, you can't escape. Thank you very much for volunteering. We then move on to the schedule of business. Again, this is for approval. Sarah, back with you.
Thanks, Russell. So this maps out the business that the board can expect to see during 22-23. Amendments have been made to reflect the foundation group board meetings that are happening on a quarterly basis, and the draft version was shared with the execs prior to submitting to the board. So it's for the board's consideration and approval, please.
Great, thank you. And I know those sort of schedule of businesses are never easy to put together. Any questions or perspectives on the schedule of business for the board? If you're not happy to approve, please raise a digital hand. Okay, duly approved, thank you. And we then move on to, again, something that we've discussed before, which is the annual trust and foundation group objectives. Glenn, over to you.
Thank you, Russell. So these went through our confidential meeting last month and were approved in draft form. So this is for formal public board. These set out an ambitious set of objectives for the coming year, and what we will do once these are agreed is put them into the board assurance framework, also put them into the individual objectives of directors and cascade them through the organisation and do organisational communications of them, and actually communications with our members also. We refer to them as trust and foundation group objectives. The foundation group element of this is the way we're handling that this year is there's a number of these objectives that are common to all three trusts in the group, and indeed also to our associate members in some cases. So we will combine our strength and learning as we carry out the objectives, but each and every objective will have a responsible exec of SWFT alongside them, and the kind of work across the group will just be to ensure that we do them faster and better and share best practice. So hopefully, having seen these before, board members are happy to sign them off.
Great, thank you very much, Glenn. As Glenn has indicated, we've seen these before. Any additional comments, team? Please raise a digital hand. Okay, if you're not happy to approve, please raise a digital hand. No raised hands, so we universally approve. So thank you, Glenn. Thanks for your hard work on that. And we had a really good session at the Foundation Group Subcommittee last week, where again, the energies in terms of pushing the agendas on workforce, productivity and left shift were the priorities identified in terms of work streams at that subcommittee level of the year ahead, in addition to all the other important stuff we're doing. So we're now into the board performance review and assurance part of the board. So Glenn, the Chief Executive's report, how do you see things?
Thank you, Russell. So always a lot going on. The delivery plan for tackling the COVID-19 backlog of elective care is the first item, also referred to as the elective recovery plan, which I talked about in summary form at the last meeting, and since we've met, it's now come out in final form. And it's a really good transformational plan, including quite significant redesign of things like outpatients, moving to more patient-initiated follow-up, moving to more digital routes for follow-up, and through that creating more capacity for us to tackle the backlog that exists across the NHS. And the plan sets out some milestones for achieving that, the first of which actually is in the first quarter of next year, where we will have eradicated 104-week waits, but we'll talk about our local position on that later. And then by the end of the 3-year strategy, we will have got back to a position where there are no 52-week waits across the NHS. And along the way, we obviously need to ensure that we support patients and provide information. I think one of the things that's key in this is the way we're going to use the entire NHS capacity to deliver these improvements. And as our local waiting list position is generally one of the better positions across the NHS, we can expect to be in a position where we're offering mutual aid to other systems, and conversations have started on that, and I'll come back to those in a moment. So our local response to this is to build on the plan that we looked at last month around our estate strategy, and particularly the need for us to address the backlog maintenance issues associated with our day case unit. So we put forward a plan through a regional approvals process that would build a new day case capacity, overlap it with our current capacity, and help to address the backlog during that overlap period, and then move back to just having our new theatres at the end. That's gone into a regional capital process. It's oversubscribed, and so within the next couple of weeks we should hear whether we've been successful in that. As I say, as an integrated care system, Coventry and Warwickshire doesn't really need investment because our waiting list position is good, but nearby we have some very long waiting times, and particularly for us, the nearest of which is University Hospitals Birmingham. So we have already been in discussion with them, offering them help with mutual aid, and that's a feature within the plan that we've submitted. My local response also refers to, though, I think the most important element of this strategy for the NHS is managing urgent care. If we can fully use the elective capacity that we've got, then that will go a long way to addressing recovery. So we don't necessarily need to spend lots of money on accessing new capacity as an NHS, but we need to manage urgent care. So I've referred to Operation Ring Fence. We're doing that across the group. SWFT is in a very good position on that. In fact, when we were visited by the national clinical lead for the Getting It Right First Time initiative, we were referred to an exemplar, and they're looking carefully at how we manage our urgent care activity, which isn't easy, and Harkamel will come back to that later. But by ensuring that that activity stays within the urgent care footprint, we protect elective work, but actually we ensure that patients are treated in the right part of the system with the right teams, which is a safety initiative in itself. So we will continue to push that through the course of this year. One of the other advantages of the way that this national framework has been set up, which we've helped to influence, is that they will pay individual providers for doing the activity associated with recovery. So that will feature as part of our income plan for this year, that we can deliver reasonable levels against that. I then referred to the annual staff survey. That's embargoed, so I can't share the detail of that. I give one or two snippets that I'm probably allowed to get away with in here, but as board members will have heard me say every year, this is the most important indicator that crosses my desk. And it's great to see that this year's set of results are as good as we've had in previous years, where we're identified as one of the best performing trusts in the NHS. It's really important that the indicators within that look at how engaged our staff are, how we handle safety issues, how we ensure that our staff are proud of the services so that they'd recommend them and they'd recommend us as an employer. So we'll be pleased to see those results coming out. I think it's fair to say across the NHS, the survey shows the level of fatigue and pressure that the NHS has been under. So the national results dip a bit, which is really understandable based on the 2 years of managing COVID that we've been going through now. But our results are really encouraging. As ever, there'll be some areas that we can improve upon, and we'll build on those, and those are built into the objectives that we just signed off earlier in the meeting. Then there's a piece on our community children's nursing continuing healthcare team. Absolute value for money as well as quality here. In most other parts of the NHS, these services are outsourced to independent providers and are quite complex and quite expensive. We maintain a very big caseload, 244 patients, 15 of which would be in critical care if they weren't being managed by these intensive support teams in the community. So fantastic team, and as I say, really good outcomes for our patients. So that's all I was going to draw out. And at the end there, we've got those fantastic winners of our latest Going the Extra Mile awards. Questions.
Thank you, Glenn. And it was good this morning at the board workshop to be joined by Justin Greening, who talked about the great work that Anne and the team are doing on the levelling up agenda. So lots of positives around the organisation. Questions or perspectives to Glenn? Please raise a digital hand. Simon?
Thank you, Russell. Glenn, the situation in Ukraine is clearly raising issues around the world and locally about cybersecurity. And I just wondered, what position have we got? What additional actions have we got in place to mitigate any potential problems and up our security?
Glenn, you're on mute. You've been hacked.
That's first schoolboy error on that for a long time. So apologies. Yeah, we are at a heightened state of alert on this from an NHS perspective. We're updating actually our cybersecurity policies across SWFT and George Eliot right now, by chance anyway. But we're keeping a really close eye on protecting and reminding our staff about the things that they can do to help us by not opening emails that they're unaware of, for example. And probably actually, Simon, as you say that, the other thing I should mention is that we've sent out some internal comms to our staff, some of whom are from the Ukraine and have relatives there, just to show our support for them, but also some of our staff from other parts of Eastern Europe, including Russia, just to demonstrate that we're supporting all of our workforce through these really difficult times and showing them how they can help and the connections they can make for support. So that's an important message too.
Thank you, Glenn.
Thank you, Glenn.
Rosemary?
Oh, sorry. Glenn, you mentioned in your report about the all the great work with the caseloads of children with significant nursing needs. And I just wanted to understand going forward how the costs of that complex care will be funded, because I understood that we will be taking on that responsibility in the longer term, but from discussions this morning it implied that the CCG would still have the funding.
Yeah, there's two. Thank you, Rosemary. There's two separate elements here. So the continuing healthcare for adults is something that still sits with the CCG and will go into the integrated care system budget. Ultimately, that will devolve itself down to us, and we'll be keen to have a look at that and see what we could do in collaboration with primary care and others in order to contain that. But it's been a growing demand scenario. The children's services are separate to that, and they've been under contract with SWFT for a number of years now within a block agreement, and we've been doing a remarkable job, actually, to the team have to contain that within that funding. Discussions are underway with commissioners to see if we can acquire some additional funding just to cope with that ever-growing caseload, but that's already a devolved budget, so it's different to the one we were referring to earlier.
Okay, thanks, Glenn.
Great, thank you, Glenn. Any other questions? Otherwise, we'll move on to the detail of the integrated performance dashboard. So, Anne, I think we're in your hands initially for an overview of the IPD, please.
Yeah, no, thank you, Chair. Just start off by saying thank you to the chiefs who have drafted the managing director's commentary this month while I was on annual leave. They've drawn out the key areas of focus relevant to their areas of responsibility, and really just handing over to them now to go through the detail. So I'll hand over to Becky.
Thanks, Anne. Thank you. Just to draw out, I suppose, a few key points from the Chief Nursing Officer's report. So just to draw the board's attention to the great work done by the teams to improve the compliance rate with the I Want Great Care. So we can see this month a real improvement in the percentage, but just also to pull out that A&E clearly are still struggling. But we've got a new approach being implemented in the month of March to use a text messaging alert. So I think we're hoping that that will reach a wider audience. And we'll see that response rate improving. The number of falls remains stable, but I'm pleased to say that the harm rate came below threshold this last month, and that's despite the increase in acuity and complexity of our patients, so that's really reassuring to see. And the other thing was just in terms of medication incidents. So we've seen a reduction in the harm level from last month, which was at 6.4% to 4.3, which is really good. So we're only just above now our internal stretch target, but just probably to mention that the national target is 10%. So we're doing really well, considering the amount of discharges and the risk that we're taking to get patients out into the community. So those are probably the key points to draw out if there's any further questions.
Thank you, Rebecca. Questions or perspectives to Rebecca? It partly goes across, I think, your areas, and Anne might have a view. How are we doing at the moment on medically fit for discharge? Okay.
As of today, we've got 39. We've got 39 delays, and in terms of medically fit for discharge, or the patients that don't meet the criteria to reside, we've made a significant amount of progress on that. So within the region, we're showing us one of the areas that have actually done the best. As of yesterday, I think it was 62. So that's where we are. Okay, great. Glenn, is there anything you wanted to add on that?
Yeah, I mean, it has been a really good response to that. The National Discharge Task Force are using some of the material that we produced as a guide to some of the other sites that they're providing intensive support for at the moment. So as a best practice guide. We're also actually being approached to provide some best practice advice on discharge to assess, which will again feature as part of some more national guidance in the spring. So this isn't discharge is not an easy area. It's one of the areas where, as integrated care systems, we will hopefully be able to make even more improvements. But the response of the team here has been great.
Thank you, Glenn. And Rosemary?
In light of the Ockenden report and recent publicity on maternity, will we be removing the C-section targets from our table?
Yes. So I think Rosemary was just trying to get out. Will we be taking the C-section stats out of the IPD? And I think the answer to that is yes, isn't it?
Yes.
Yeah. And it's important to remember, and maybe we'll come back to it a bit later, but in the past, we've often been challenged on our C-section rate as being high regionally. But when you see the issues coming out of the Ockenden report, it clearly could be argued that that was not a negative. And then David, and then we'll move on. David?
Yeah, I was just on the point of taking the C-section rates out of this state. I do have a slight concern on that, is because of course we could end up having very low C-section rates, and we may not actually have visibility of that. Or am I being a bit over cautious?
Half an hour. Your hand went up with enthusiasm.
Yeah, so it's just to say that we are we're reviewing how we frame some of the reporting about this, because actually you'll notice that in my report it says decrease emergency cesarean section rate, which suggests that we're trying, that's what we're trying to do. What I'm proposing is that we will just report the actual figures, and then I'll highlight any areas of concerns or any adverse trends or anything that I need to highlight. But I think in terms of the actual data, I think it's important to feed that back. I just think we could do better.
Yeah, I mean, the reason I'm concerned is because, of course, emergency section rates could actually rise, and that could be an indicator, couldn't it, of us actually not intervening early enough. And I'm quite mindful that this is a hot topic at the moment, and I just don't want the board to lose sight of the actual information, because it could deteriorate without us even knowing if we're not careful.
Yeah. Thank you, David. And finally, Glenn, and then we'll move on.
Yeah, as David alludes to, as does Harcombe, I think this is something that I think the criticism of other organisations was that putting targets in place, but this is a good indicator. As long as you're not trying to suggest that you kind of move to a blanket target.
Yeah, and as Dilly's put into the chat box, we will continue to monitor normal delivery, section rate, instrumental rates, etc., through the maternity and divisional governance. So thank you, Rebecca. You can relax for a few minutes. And we'll move on then to Harcomel's report. Harcomel.
Thank you. So our A&E performance in January fell from the 72.4% that we achieved in December. So we achieved 69.9% in January. I think it's important to note that within the month, we did start off at around 68%, and that was where we sort of stayed for the first couple of weeks. And we managed to improve our performance to 71.8% for the rest of the month. And despite not being quite where we would want to be as an organisation, we were still higher than the national average. So the national average for type 1 providers was actually 63.2% in January. As predicted, attendances did increase in January following the lull sort of over the Christmas period in December, and flow remained very challenging. Our medical bed occupancy reached a high of just under 94%. And that was mainly on Sundays and Mondays. And so that made flow then very difficult and the start of the week very, very challenging. We also then overlaid all of that with multiple bed closures, so due to COVID, and that presented significant pressures just in terms of every plan that we had. We then had to completely review it and make decisions perhaps that would have been more challenging. I'm sure if Fiona was here, she would echo that. And the admitted position remained a challenge, as I sort of explained. In terms of our attempt to try and manage that, we did run a MAID event, a multi-agency discharge event in the middle of January, and that did help our performance. So we are reviewing how we take some learning from that and try and make that a bit more of a sustainable approach that we can just do every week moving forward. As I said before, delays out do remain a challenge. So as of today, we have 39 patients in our beds that need not be here, which is obviously very difficult for us. Moving on then to RTT, our performance dropped a little bit to 78.4%, but that is stabilising as we expected. We remain on track to have no patients waiting over 104 weeks by the end of March for their treatment. Diagnostics, we didn't achieve the 97% diagnostic standard, but we did achieve 96.9% of our patients being seen within 6 weeks. And our cancer performance remains stable. So we still are seeing delivering a higher than pre-pandemic number of treatments, and we are seeing a higher than pre-pandemic level of referrals. As I'm sure was said last month, the focus is on the 28-day standard, and that comes into effect in April. We achieved 62.7% for December and predict around that for January. Those figures will come out on Friday. And finally, then, in relation to our elective restoration, we achieved 96.7 clock stops against our plan, which is very strong performance, especially when you consider how challenging flow was. And we did incredibly well not to cancel a single elective due to bed pressures in January, despite many phone calls over many weekends, considering whether that was the right thing to do or not. And then my last point, I just wanted to point out that we've been doing ERF for the last 10 months, and we've achieved whichever target, so H1 or H2, for 9 out of those 10 months. And notably, we've seen a significant reduction in the number of patients waiting over 78 weeks for treatment. And I think that's just I'm really proud to be able to say that, I think, at this point of the year, given the challenges we are facing in terms of beds and flow.
No, thank you, Harkamel. Everyone, all of the operational team, all of the frontline teams are doing a phenomenal job. Really, really well done. Questions or perspectives to Harkamel? David?
Yeah, it's an observation. You make a comment that ambulance transfers 20% up from out of area. Do we get any recognition for what is in effect mutual aid for other areas? Because in effect, that's what it represents, doesn't it? Or is there another reason why we're requiring these additional? And of course, that has a knock-on effect in the A&E department, doesn't it?
Yeah, it has a huge effect. So in terms of recognition, not really. The recognition I would want to see is for those ambulances to perhaps spread out a little bit across the patch, as it can be quite challenging. Certainly, we are working much more closely with the ambulance service lately, just to try and understand some of those patterns of referral and then unpick what could have been done better. And I think that work, in my opinion, needs to be ongoing for the next couple of months at least, because it does present a significant amount of pressure for us. That said, though, when you unpick why those ambulances end up here, they are coming from regions that are facing significant pressure. So, for example, we had ambulances arriving after having waited already for 9 or 10 hours at another site. So, we are not seeing delays in that region.
Yeah. So it is mutual aid then.
Yeah, just in an ad hoc fashion.
But without income benefit. I mean, it's worth just for members of the public, and Glenn, if I get this wrong, please correct me. In the going forwards as we come out of this financial year, effectively we were incentivised for doing more elective work, but we're effectively given a block contract to do emergency work, people turning up at A&D. And so David's point about it being not just mutual aid, but it's mutual aid without any financial benefit. That's correct, isn't it?
Yeah, the elective work will be paid as we go. The urgent care, there's an adjustment to it that takes account of out of area, but it's certainly not a payment by results type model, but that has grown over the last few years because of services around us, including for example, Solihull Urgent Treatment Centre closing. So yeah, we certainly are seeing more activity coming our way.
Yeah. But I think it's important for us to remember we're part of a national health service. We're not the Berkshire Health Service. And Sue?
Yeah, hi, Harkamel. I really echo pride that you feel about the elective work. It's it's been so busy, and it's really a huge testament to all the teams. I just wondered on urgent care, you've talked about discharge work and the MAID event. What about admission work? Because obviously most of our attends are from within our region. So what's happening in terms of working with partners as COVID shifts to make sure that we have got people in the right place?
So that work has been ongoing, and we haven't necessarily scaled any of that back. So in terms of working with our partners to try and do some of that discharge planning, we are trying to focus our resource into trying to, for example, encourage people to use advice and guidance and to make sure that they're using NHS 111, because we can really see the benefits when those specialties sort of come online. And not to mention sort of the wider prevention agenda. In terms of admission prevention, the thing that works really well for us is having our SDEC areas open, so where our GPs can refer straight into SAU, for example. And what we've seen in January and with these bed pressures is that we were not able to maintain those as assessment areas for patients to come in, be seen and then leave, because we had to bed into them, given the bed pressures that we were sort of facing. So moving forward, and in an ongoing way, I think that is where that's the key to having good flow, having those assessment areas open and making sure that our partners retain confidence in those areas being open so that they can direct their patients there will be the key, I think, to improve our performance and sustain that.
Thank you, Sue. Thank you, Harkamel. And then finally, Simon, then we'll move on. Simon.
Thank you, Russell. Hello, Harkamel. Harkamel, there's a very big gap, in fact, between performance on non-admitted A&E and admitted A&E. And can you just explain to me why that is and what are the key drivers of the disparity in the performance?
So clearly the admitted is all around the aspects that I've spoken about in terms of when we don't have the beds available in the place that we want them, we can't move patients through. And certainly that's where we see most pressure, I think, then on Sunday and Mondays, and that's when we're likely to have our lower performance. And that is all just around flow and discharges are becoming available, and that's why the MAID event was so important. In terms of, sorry, Simon.
No, keep going. Sorry.
So in terms of the non-admitted, it all kind of ties into the same picture. We see days, or we saw days in January where our attendances exceeded 270. We just never used to see volumes like that. So then, despite whatever pathway these patients are coming on, the time to then assess them then just gets bigger. So that's where you then are in a hole in terms of the volume of patients and hampers the ED ability or the ED team ability to respond effectively. So on both pathways, that's sort of where you're seeing like the issues, but they are driven by different things, albeit seen in the same small bit of the ED.
Okay, and of the 30 organisations ahead of us in performance, are we able to see things that they're doing that would help us perform better on A&E, or is that an invisible thing for us to see that help?
No. Really, so I'm really glad you asked that, because we have one of the things that we started to work on now is to try and understand on those days where we have really poor performance, can we develop a picture of what were the days like leading up to that, what were the discharge numbers, what time did people arrive, and all the rest of it, to really have kind of a picture to try and give us more clues. So as part of that work, we did start to look at some of those other EDs, and we're trying to understand if there is anything that we can learn from that. They're not always the same EDs though. So in December we were in the top 20, and then we fell, and that is the picture sort of nationally. It just fluctuates, and that makes it really hard, because that would be useful.
Yes, indeed. Harkamel, thank you very much.
Thanks, Simon. And Harkamel, you mentioned 270 A&E visits a day. Before COVID, what would that number typically be?
So we never got to 270 prior to that. We were around, I want to say, between 180, and the highest at pre-COVID was a 207, 210 type day was considered a bad day. On an anomaly, you might see numbers higher than that, but not very often. But I am pulling some of that information as well, just so that we can try and triangulate if there's anything that we did pre-COVID on a good day that we could do back then. That said, you can't really compare it with that, because you did not have the dynamic of the patients coming in with suspected COVID that you then have to try and manage. And we did see a lot of incidental COVID.
Yeah, no, I understand, but 180 was a number I had locked in my mind. Glenn, I want to move on. Is it a quick one?
No, I was just going to say, we've got all the other routes into the hospital now, including the SDEC. But maybe I've been here too long. But when I first arrived, I remember about 130 was a bad day. So it's doubled. Yeah.
Okay, great. Well, not great, but you understand what I mean. Okay, so we'll move on then to Gertie. Gertie, suffering from a cold, but with balm tissues to hand. Gertie, what would you like to pull out of your report?
Thank you, Chair, and I'll be brief with this. I'll just pick up 3 or 4 key points. First one is it's really positive to see the high numbers of new starters that joined us in January, particularly in our registered staff and our clinical support workers, which is very positive. Sickness remains above our target. However, I think it's worth, in terms of some context for that actually SWFT is one of the lowest providers, and it is the lowest provider in the Coventry and Warwickshire system. So although it's higher than we would want it, we are certainly performing better than a number of our peers. The other 2 areas I'll quickly flag is appraisal and core skills training framework compliance. These are both areas that we have stopped and started throughout the COVID pandemic, and obviously we are seeing some impact of that. We had some really good discussions at the FPE last week, and had a conversation with the divisions about their developing trajectories to give us assurance that they are picking these up and when they will come back online. So I wasn't going to take anything else specific, but happy to take any questions, Chair.
Thank you, Gertie. Any questions to Gertie? Okay, thank you, Gert. Sorry, Sue.
Yes, just quickly, you say there's no trends in the reasons for leaving. I'm sure there are. I mean, I don't mean that to sound too pushy, but you know, perhaps we're normalising what we're seeing. So I just wondered if we could see what those reasons for leaving are as a one-off at some point, so that we can just take a look at that. Thank you.
Yes, I think yes. I think you're absolutely right. There are definitely trends for leaving, and I think equally we need to remember that some of those leavers are moving on to other roles within the organisation as well. But I'll certainly bring back, if not next month, then by April, we'll have a deep dive into that and share it with the board. Very happy to do that. Thank you, Sue.
Thank you, Sue. Thank you, Gertie. And then Yasmin.
Thank you, Gertie. My question was around the skills shortage that is mentioned in the pathology side, and you said we've had a new starters, quite a few. I wondered if that is going to address some of the shortages there.
For pathology, I think we're spread across a number of areas. I'd have to take that one away and come back to you in specific in terms of the detail. I think pathology is probably not addressed by the new starters we've had coming in. That's more of our primary ward areas and the community. But I can go away and look at that and update you offline, Yasmin.
Oh, that would be great. It'll be good to understand how we are addressing those skill shortages, because it's been raised as a concern in another chief officer's report. Thank you, Gertie.
Yeah.
Just one more thing, Chair. I wonder, Gertie, if you can say anything around the International Women's Day that's coming up, and are there any events planned?
Yeah, absolutely. So we are planning a joint celebration for International Women's Day across Coventry and Warwick. And as a cohort of chief officers, we have got plans in place to celebrate and share stories and to support women. And we've also been starting some conversations about a collaborative network, a women's network for Coventry and Warwick, because we think that's a really great way to connect and to support. So thank you for bringing that up, Yasmin. It was on my list, but I've forgotten to bring it up. Thank you.
Thanks, Gertie. Yasmin, I'm not sure if you're treading grapes or you're on a bike or you're on a treadmill like me, but either way, you're obviously keeping your body moving, which is a good thing today.
I have taken your advice and bought the exact same treadmill that you are treading on.
Okay, it's becoming a trend. Don't fall off. So we'll move on then to the finance numbers. Kim, over to you.
Thank you, Chair. So just wanted to report to the board that we are currently delivering a £24,000 surplus. We're on track on that basis to deliver a break-even position. However, I just want to update the board that we are currently in discussions with NHSIE about some potential changes in accounting treatment, which may result in a technical deficit. But as I said, those discussions are ongoing, but I will keep the board informed as appropriate.
Okay, you've been briefed on that outside, Kim, so thank you for that.
Okay, thank you. And I just wanted to draw attention to one more thing. You'll note on the balance sheet there's a movement in terms of the reduction in investments in recognition of the fall in the share price of shares in the Sensign. If those board members who were with us a few years ago will be familiar with, is that on initial recognitions of Sensodyne shares, when we made the initial investment in the Sensodyne shares, the board took a decision to make an irrevocable election under IFRS 9 for the equity instruments to reflect fair value movements through the other comprehensive income, and in doing so any movements will be reflected in the equity reserves but had no impact on our INE position. So just wanted to make sure that the board were, noted that movement on the balance sheet. But otherwise, happy to take questions.
Thank you. Any questions to Kim? Had a big session on the numbers this morning for members of the public to be aware of. Glenn?
I mean, just as Kim said, the potential adjustment to this year. We need to decide whether we do that. If we do it, it would be because it would give us an advantage in future years, just to add that note.
Thank you, Glenn. Okay, mortality. Charles, I think you're with us. Thank you. Charles, is there anything you'd like to add to the mortality report? I said that Charles is with us. I don't think he is with us. I think he's at the dentist. He was with us a bit earlier. So I'll take the mortality report as read. Any questions on the mortality report for minuting? Okay, so I think we're back with you, Rebecca, on the monthly safe staffing report. What would you care to pull out?
Thank you, Chair. So the report demonstrates that we've got a consistent position with the gap for the nurse inpatient staffing. We're sitting anywhere between kind of 4 and 6% over the last few months, and that's the gap between the planned and the actual staffing level, so that's quite consistent. And as Gertie said before, we do have a lot of internal moves, so our gap tends to stay the same, although people are moving across wards and departments. I hope that the report really provides you with some assurance that the corporate nursing team, alongside our operational colleagues, have got close oversight on the staffing risks and mitigations, and you can see in the report there we've drawn out some of those risks that are on the local divisional risk registers. I suppose I'd like to just draw your attention to the continuing complexity really around the patients that are suffering with mental health and dementia needs, and the need for increased level of supervision. In particular, you'll see we've mentioned in the report around Charlcote Ward, who I'd really like to highly commend on their management of a group of patients, but one particular patient with an early onset of dementia, who was in the organisation for 4 months, who I'm pleased to report that has just been discharged on the 8th of February. But they've been commended by our partners as well in terms of the management of those behaviours and assisting that discharge for that patient. We're drawing up some work around one-to-one specialling and what that model looks like, and whether we can do something in-house to really bolster the care of those patients suffering mental health and dementia behavioural needs. That's it for me, unless anybody has got any questions.
Really great summary, Rebecca. Thank you. Any questions or perspectives to Rebecca? We're obviously going to be talking about midwifery in just a second. Rosemary?
Yes, Rebecca, can I just explore the case of the person in Charlcote? Were they there for medical, was their stay that long for medical reasons, or was it because there wasn't a place and a suitable accommodation for them?
Yeah, unfortunately, Rosemary, the patient never had a medical need to enter our organisation, so it was more of a breakdown in his environment at home. He was out of area, which further compounded really the delays in terms of getting the patient out. He had very complex needs and wasn't accepted at quite a few higher level dementia units, etc. So it took a lot of working with our partners, CCGs in Birmingham, etc., to find suitable placement for this patient. So it took that long, unfortunately, to find him somewhere to go.
Yeah, I mean, great work that the team have done in terms of looking after the individual, but in terms of the financial impact for us, it's
massive.
It's
really estimated about 220k for the care of that patient over that 4 months.
And will we be able to get any reimbursement for that?
I might go to Kim for that, but I don't think so from my understanding, no.
But that puts it in some context. For 12 weeks of care, £220,000.
Yeah, it's the 24/7 2 RMNs that really.
I understand totally, Rebecca, but it just goes to show this: the system collectively must do better. On an annualised basis, you work out the maths. That's about £800,000 to £1 million, £800,000 to £1 million a year. You know, the system must do better. And
yeah, just on that point, in terms of the system doing better, there are plans to review this case, work with partners in terms of future learning and how we do better, because it's not just the financial cost, but the cost to the individual.
Absolutely.
And families.
Yeah, absolutely. Okay, thank you, Rebecca. Thank you, Rosie. And we'll move on then. And obviously, in the context of last week's Panorama programme and Ockenden report, which came out a few months ago, and there's another Ockenden report coming out next month. Our maternity team are doing absolutely phenomenal work. And I just want to put on public record my thanks, the board's thanks for the phenomenal efforts of the frontline maternity teams, but also the sort of work that Dilly, Linda and others are doing. So great to see you digitally this afternoon, Dilly and Linda. Do you want to talk us through your maternity governance report, please?
Yeah, I'm happy to do that. Thank you, Chair, and thank you for that very nice introduction. So, as you know, NHS England and NHS Improvement had asked us to submit a discussion with the board regarding SWFT's maternity services current position against all the maternity safety and quality key performance indicators, but also to share the progress of our action plans in terms of recommendations from Ockenden and the Kirkut report from Morecambe Bay. As well as our Saving Babies' Lives 2 care bundle, our continuity of carer implementation and our safety workforce plans. Our position will also be shared with the LMNS and ICS later this month. So sadly, we've had one reportable case to the Healthcare Safety Investigations Branch, HSIB, in this quarter, and this is where they will be independently carrying out their investigation. So this brings the year-to-date cases that we've reported to HSIB to 10. However, 8 of those investigations have been fully investigated and reports shared with the all the families, and all the recommended actions and learning has been embedded within our maternity service. We've sadly seen 5 perinatal deaths this quarter. All of these cases go through our perinatal mortality review tool, and this is to ensure each case is reviewed to enable us to provide answers to each of those bereaved families, to tell them why their baby died, but also to explore you know, how we can improve, what we can learn, but ultimately how we can prevent future deaths. Within the report submitted, you will see the predicted likelihood of SWFT meeting the CNST Maternity Incentive Scheme Year 410 safety actions in the recognition of the current pressures within the NHS and maternity services. The reporting requirement was actually paused on the 23rd of December 2021. However, this didn't deter SWFT from applying those principles where possible despite the pause, because ultimately we want to deliver safe maternity care. For example, we have continued to undertake a workforce review, and as far as we can, we have continued to have possible oversight by the Maternity Safety Board champions, as well as continued with all our virtual maternity training. We continue to make good progress on our Ockenden work. Our action plan shows that the most direct patient safety actions have now all been completed, and the work that continues on all the other actions include progresses to be made in reporting process and data collection. NHS England have provided some very useful assessment and assurance tools, and this is to enable us to benchmark ourselves against the national safety standards for maternity. We've started work on all these 3 tools, and we've already met a significant number of criteria, and the work will be finished on these tools by the end of March. As you know, a birth rate plus assessment of SWFT maternity services was carried out back in 2019, but reported to us at the middle of 2020. The Royal College of Midwives and the Royal College of Obstetricians and Gynecologists recommend the use of this birth rate plus tool to enable trusts to recommend and calculate the overall clinical establishment to make sure we can provide safe maternity care to our women. So at SWFT, the recommendation from the birth rate plus assessment was 119.52 whole-time equivalent clinical midwives, and this would enable us to achieve the safe birth to midwife ratio of 1 to 26. However, unfortunately, the recommendations weren't fully implemented back at that time, and compelled with the staffing challenges we saw in the later summer months, and we escalated our concerns to the Chief Nursing Officer, and then we had a request from the CNO to do an internal review of the workforce, which we did, and this was to seek assurance that the midwifery staffing establishment did support the provision of safe care at all times. This review was completed in January 2022, and it produced very similar results to the birth rate plus assessment. So therefore, we do need an investment in maternity staffing, and then we are now in the process of putting a business case together to be able to achieve this. So in order for SWFT maternity services to achieve the successful delivery of continuity of care, safe staffing must be in place. This is the first building block that needs to be in place before we go any further. But we are continuing to work with our continuity of care model. We approach it as a team model of continuity of care, concentrating and prioritising our antenatal and our postnatal continuity. However, for our women who are most at risk of having a poor outcome, we are prioritising a full continuity of care package to include the intrapartum care. So this would include our BAME population, our mothers who suffer perinatal mental health, our young mothers who live in and areas of social deprivation, alcohol and substance misuse, and particularly in South Warwickshire, we have a very large population that suffer with diabetes. So I do hope this report provides a high degree of assurance to the board, and I know the maternity team are committed to the delivery of the safe maternity service. And I just wanted to take the opportunity to thank the board for your message of support to our staff following the Panorama programme, because this really reflected how the Trust value our staff's wellbeing. So thank you very much.
Thank you, Linda. Dilly, anything you want to add?
No, I suppose just to say how nice it is to come to board this month, because from the very beginning, from the first words that you said, maternity and paediatrics have been at the heart of what the board does. So it's great for Lynn, Becky and I to sit here and hear this.
Okay, great, thank you. Questions and perspectives, Glenn?
Thanks, Lynn, and thanks for the great work that you're doing. Just on this, I mean, obviously we've discussed the continuity of care model before now, and I think it's widely recognised that it requires more midwives, but delivers better outcomes, which is obviously something that we therefore strive to implement. We've gone further and faster than a lot of organisations on this. Is there any kind of benchmark about how much we've implemented this compared to your average trust?
So no, the answer to that is no, actually. The next benchmark that we need to hit is we need to get 71% of our vulnerable women on a continuity of care, you know, and a lot of the trusts nationally are catching up with us anyway. We made a really good start. COVID obviously has paused a lot of it, but we never we were in a position that we were able to offer all our birth choice services throughout the pandemic. You know, temporarily we did have to suspend some of the services, but very temporarily. So we continue to build on the foundation of the continuity of care that was already put in place for us. So we are still on target. We still have got work to be done, and we're now working with the National Lead for Continuity of Care, Trixie Mackery. She's actually coming out to visit us at the end of March, so she will help us move forward with the transformation.
And just on that, if I may, Russell, we've got an exec team meeting with the national team coming up very soon. They've been visiting all trusts, and they've done it on a risk-based approach, and so we're one of the the last visits, which is really encouraging for our team that they didn't want to see us the other side of Christmas, which has been a number of organisations have.
No, thanks, Glenn. Thanks, Linda. Thanks, Dylan. Can't see any other hands up. I just want to recognise, Dilly, I think you're retiring this month. It's either this month or next month. Dilly, you've been an unbelievable, use the phrase, servant of the trust, and I just want to put on public record our enormous thanks as an organisation for your many, many years of service, and you will be greatly missed because you're greatly loved. But take care and enjoy your retirement. Sue, did you have a question? Sorry.
Yes, sorry, I was a bit slow. Linda, thanks. Great to see you here today in this report. I would like a copy of that continuity of care detailed report, and I just wanted to thank you for your openness and transparency. And I think that there's some really important discussions around SWFT's journey on continuity of carer, and it would be great when you're next here to understand what that forward trajectory is. But absolutely with you, it's safe staffing initially.
Thanks, Sue. I'll send it to you.
Okay, team, thank you. We need to pick up the time a bit, team. We're running a bit late down our very long agenda. So really great now to welcome Deepa, who's going to give us a Freedom to Speak Up Guardians report. Deepa, lovely to see you again. It feels like only yesterday since I last saw you. Deepa.
Doesn't it just? Apologies to anyone that was on the call yesterday for any repetition, but I'll try and be swift for today's report. In the reporting period up to the 31st of January, there were 25 cases brought to the Freedom to Speak Up team, and majority of those were raised on a confidential basis. After the 25 cases, just pulling out the main divisional areas, 6 out of hospital, 5 support services, 4 elective, 4 family health. And in terms of the themes that were coming out of those cases, 5 staffing levels, 5 bullying and harassment, 4 policy, procedure and process, and 4 patient safety were the key themes. Staff have continued to report staffing levels as a key area of concern, which includes the movement of staff from one area to another due to shortages. We're also hearing frequently of staff having to work on their off-duty or non-working days to complete things like mandatory training or meet general workload. That was an issue that was raised at board previously, and action was taken away to raise at JNC. That was completed, and as a result, a safe staffing presentation took place at JNC with Gertie and Fiona, and execs have agreed to continue work with those areas where there's acuity and staffing levels that feels unsafe. Our Speak Up Wellbeing and Inclusion ambassadors have been hearing concerns regarding change of services, especially in the urgent response areas, where the teams are extending their service provision in line with National Ageing Well agenda. They're hearing concerns regarding behaviours and relationships, and we're hoping that with the increased delivery of civility training that people will feel more comfortable to tackle those issues as they arise, and keeping those at the lowest level without involving formal processes. 4 cases in relation to patient safety or patient experience. Action plans have been put in place in those areas, which are being managed through divisional management channels, people and workforce, PALs and Speak Up teams and trade unions where appropriate. With regards to the civility training, we've continued to deliver that almost on a weekly basis throughout George Eliot and SWFT. We're reaching over 700 staff, but that number is probably closer to 800 now. We've had some train the trainer sessions to increase the pool of facilitators that can deliver that training, so that then Sue and I can move on to work on a package of training which looks at the second to messenger technique, and as an advanced level of the civility moving on from that. The sessions are generating good feedback, and just to highlight one comment that was came through. Staff should have confidence in challenging incivility. Just because some people behave in a certain way doesn't make it right. We all have a responsibility, no matter what position we hold, to address inappropriate behaviours in ourselves and others. And in general, the overall rating, when people are asked about the session, 97% of respondents have given it either a 4 or a 5 out of 5. We're continuing to work with Y Valley as well, to ensure that the civility offering is covered off across the group. In terms of our ambassadors, we've continued the recruitment drive across both trusts, and since the last report, we've recruited 13 new ambassadors within SWFT. We've been able to deliver some bespoke learning sessions for the Speak Up Wellbeing and Inclusion ambassadors from With Staff in Mind for mental health support for staff and poverty proofing training as well. We recognise there is more work needed around diversifying our ambassador network, and we hope to work on that in terms of gender, inclusivity in terms of all protected characteristics and shift patterns. With regards to feedback, there were fewer responses in terms of speak up feedback. However, all responded to say that they would be happy to speak up again, satisfied with the speak up process, not always satisfied with the outcome, and that's reflected in some of the responses received. In terms of next steps, they're bulleted in the report. I won't repeat those, but we will be now looking to put in place some arrangements for activities for Speak Up Month later in the year in October. Happy to take any questions.
Deepa, just before we go to questions, you're having a really great impact. It's great to have you on board in the role. Thank you.
That's really kind, thank you.
It's Glenn.
Great report, Deepa. Really good to hear the impact that the civility training is having as well, because that's really important work. And earlier I discussed the staff survey. I'm not allowed to share the results of that, but actually one result that is quite interesting is that there's 99 questions that are asked in the survey, and in our benchmarking report, only one of those was significantly worse than average compared to our peers, and that was about staff working overtime that was unpaid. And it just correlates with the point you made earlier, and it's something we need to really keep a close eye on. That, I mean, it says a lot about the culture of our workforce that they do that, and then they still report positively on all of the other questions. But we need to make sure that this doesn't creep in as something of an expectation, and needs a strategy to tackle it.
And absolutely the knock-on effect on well-being and what that can lead to in terms of the workforce generally. Thank you.
Thanks. And Jasmine?
Thank you, Chair. Thank you for the lovely report. Of the 700 staff who have attended this training session, I'd be interested to know what the breakdown is by professional groups. Do you have that information to hand, maybe to share later?
We don't have it in terms of professional groups. We can categorise it possibly by areas and divisions who have attended, but I'd have to pull that data and come back to you if that's okay.
Yeah, that's okay. Thank you very much.
That's great. And finally, Gertie, then we'll move on.
Thank you, Chair. I mean, I really just wanted to extend thanks to Deepa. Deepa's been in post now for about 6 months, and you can actually really see the really positive shift change. You know, reaching 700 people on civility is hugely important, and actually you can see how that's shifting in terms of the conversations about behaviours. And I'll pick that up in my later report in the private board. But it's been really fantastic to have Deepa along with us working through this. And I will just formally again acknowledge that my thanks to the George Eliot charity who have funded Deepa's post, and obviously we will then continue to work to make that post substantive moving forward. Thank you, Chair.
Thank you, Gertie. Thank you, Deepa. I look forward to seeing you again soon. Carry on doing what you're doing, and we all need to remember that civility saves lives. Therefore, moving on to the report from the Council of Governors meeting held on the 10th of February, which I'll take as read, but I do want to recognise and welcome those governors who were re-elected and were successful in their re-election process, and we have a number of new governors who will be joining us, so delighted to welcome them. But any questions on the report from the Council of Governors meeting on the 10th of February, please raise a digital hand. Okay, I'd just again like to thank all of the governors for their continued hard work on behalf of the citizens that we serve. The Digital Health Board Quarterly Update. Adam, what do you want to pull out?
I'll take it as read, but two key points, I think. firstly to note that the EPR outline business case that we approved the Board of Directors last month has now been submitted to NHS Digital. We haven't had any feedback from them yet, but we have been assured it is on track for the 3-month window we were originally indicated it would take for them to approve. And we've commenced our work on the full business case in parallel. So as it stands today, we are still on track to get the full business case here in the summer. I think the second thing I would highlight is the significant amount of end of year capital funding that we've been able to get for a number of particularly infrastructure related initiatives. And that totals just under 1.3 million for SWFT. That's really good news for us, because I think it helps put us in a really good position for the EPR. There are some complexities around the finance and some particular complexities relating to the short notice of the bids and short notification of the funding. And there's a paper on confidential board later about transferring that money into Innovate. But overall, it's great news, and it allows us to do some really good stuff.
Thank you, Adam, and thank you for your hard work. Any questions or perspectives to Adam? I know Sue's been, I won't ask her to talk because she's just put something in her mouth. I know Sue's been a strong advocate for ensuring that in terms of the ability of sharing data and the protocols around sharing data are sorted, and that's absolutely key. And I know Glenn's got involved in that at ICS level. Okay, we'll move on then to the Audit Committee report for the 9th of February. Anything you want to add or pull out, Rosemary?
Thanks, Russell. Just 2 points. First of all, the external auditors completed their planning work, and at the moment they've certainly got no specific trust concerns to raise. So hopefully we'll be moving into a smooth audit for the upcoming year end. And then the internal auditors looked at a number of areas of the finance system. I'm pleased to report that all their work gave us significant assurance over the financial controls in place, which is an improvement on last year. And certainly, obviously, the new back office systems appear to be working effectively there. The one area of concern which I wanted to highlight was over patient access plans. So this was an area which internal audit looked at in early 2020, just before going into COVID, into the COVID pandemic, and identified a number of concerns and gave limited assurance on their work. So from their follow-up work, it was clear that whilst there was a long list of recommendations in place, most of those have not yet been implemented. So the concern here is obviously with over patient safety and people just not being seen for follow-up. Are not being put in train properly for follow-up. So I think there's a long list of recommendations, though we've been assured that they will be all completed by June 2020, but the audit committee will be keeping a close watch on the progress of that.
June 2022, I assume, Rosemary.
Sorry, 2022.
Good. Yes. Time flies. Thank you, Rosemary. And well done, Kim, on the improvement on internal control. Any questions or perspectives to Rosemary? Okay, and then David on the, thank you, Rosemary. David on the clinical governance report for the 9th of February. Anything you particularly like to pull out?
Only the 2 points. One relates to the nice guidelines compliance. And the trust has actually now developed a process to try and ensure that this is actually implemented, and there's still some work to do on this, because clearly there are some specialties that, whilst they probably do comply, they can't prove they comply, and so there is some work going to be done on that. And the other relates to the learning disabilities death reviews, which again, the numbers thankfully are small, but in order for us to get any decent learning out of it, we probably do need to be looking at this across the system wide. And so we want to be trying to push for a system learning disabilities provider group to look at this. But other than that, take the report as read.
Thank you, Dave. Any questions or perspectives to David? David, is there any process at the moment envisaged to get the 3 NEDs from who chair the provider version of clinical governance subcommittees in Coventry and Warwickshire ICS together? Just
it's happened once in my time. And there is an intent, because there is a new incumbent at UHCW to the post, so it's probably hoped that that's going to become a regular thing, but it's not. They haven't been formally diarised, unlike the foundation group clinical governance, which is we meet quarterly. Sorry, you've broken up there. I didn't hear you.
Yeah, that's okay. I'll try again. I'm sure you'll try and extend the hand of friendship to the new guy at UHCW.
Very definitely. It's a lady, but never mind. Yes.
I use guy in a gender neutral way. Gertie, try not to die on screen. It's not a good look. So moving on then to items for noting and information. Thank you, David. Sorry, did anyone have any questions for David? You don't have to apologise, Gertie. I was more worried about you. So items for noting and information. The summary of ratified policies. Anne?
The report is self-explanatory, Chair, so just there for noting. Thank you.
Okay, great. Any questions to Anne on the ratified policies? Then we've got the emergency preparedness annual report. Harkamel, what would you care to pull out?
Yeah, so as I said, this one too is fairly self-explanatory. It's just the assessment against the compliance for the core standards. There were 3 areas that we need to put an action plan in place. This time last year we only had the 1. So it's I suppose the only thing I'd like to highlight is NHS England are reviewing these a lot more stringently than they were previously, but we do have action plans in place and we have come out as substantially compliant.
Okay, great. Thank you, Harkamel. Any questions to Harkamel? Okay, then I think we're on to the estate strategy summary, which obviously we've talked about. Oh, sorry, I apologise, Rosemary, I didn't see your hand up.
I didn't get my hand up. My hand didn't go up quick enough. Harkamel, going back on Simon's earlier concerns about cybersecurity, I just wondered whether the cyber risks are built into the emergency preparedness programs, because they are equally.
Yeah, so they are in there, and I think they're there as one of the measures. Interestingly, we haven't actually had anything from NHSE yet, specifically around anything further that we need to do for cyber or logistics or anything yet. So we've asked the question if there's anything further, but for the moment the core standards remain as our cyber is inbuilt in that, and then that links to all of our training and our policies that we've got. So we've not been challenged on any of that, but that is encapsulated.
Needs to be kept on the radar at all times.
Yeah, no, absolutely. Thank you, Rosemary. Then we're on to the estate strategy summary. Sophie, anything you particularly like to pull out?
Thanks. Just to note that the board in the confidential section last month obviously had the pleasure of a 150-page document, and what this document does is for our public try to highlight the key drivers for our estate strategy and the key projects, some of which have been mentioned through board today around things like the Elective hub at Warwick Hospital. I guess the important thing for us now as an organisation is this does give us a roadmap for each of our sites, and also for our community estate that hopefully, it will actually align now with our trust strategy about how we deliver services in the future. And just finally to say that actually some of the next steps and the really important part for us now is just to make sure we continue to develop this with our partners at place and with the system. It's timely because the system are doing their estate strategy at the moment, so it's been great that we've been able to be really clear as an organisation and as a place where some of our key developments need to be, so we can go into that discussion in that informed way. And just to note that alongside this is our strategy around achieving net zero. So our sustainability strategy is really key to this as well. So those strategies will make sure align and we'll continue to evolve it.
Okay, thank you, Sophie. Very clear. And as you indicated, we spoke about this in a big session last month as a board. Questions and perspectives, Glenn?
Just the risk I would flag against this is that in the old regime, as a foundation trust, we would have generated internal resource to deliver this. And if we couldn't, we would have looked at business cases and potentially borrowed funding and repaid that in order to implement the plan. We're now in a rather different world where we're bidding against other organisations for shares of capital. And I'm talking to the national team about how we can make that more of a where the cost of capital is considered more properly by systems. But meanwhile, we're in a bit of a bidding process. So as Sophie said, it's good that we've got our plan in place, but it will be up against some other bids for completely different things in other organisations.
Yeah, the liberties and freedoms of foundation trusts are being eroded. Okay, thank you, Sophie, that's great. The updated Register of Directors' Interests is for noting, isn't it, Sarah?
That's right, Russell. Just to acknowledge that Charles has declared some new interests which are highlighted in bold. So for receiving and noting, thank you.
Thank you. Thank you, Charles, for updating it. Any questions on the Register of Interests? And then just polishing off the Audit Committee of the 8th of December. Anything you want to add, Rosemary? Okay, any comments? Okay, duly noted, thank you. The Clinical Governance of the 12th of January. David, anything you want to add?
Not from me, Tom.
Thank you. Any comments from colleagues? Okay, thank you for everyone on both of those. Any other business? Please raise a digital hand. Okay, can't see any hands raised. So we've got, I think, 3 questions that I'm aware of, Governors. Sarah, do you want to read each of them out one by one, please?
Thanks, Russell. So the first question is from Roger Lloyd, Public Governor for West Stratford and Borders. Under agenda item 6.3, the Trust's annual objectives, the heading of workforce has no reference to staff wellbeing and empowering staff to speak up and challenge unacceptable behaviour, notwithstanding the excellent work of the Freedom to Speak Up Guardian. Whether within the workforce or patients and the general population, should this not be included as a 4th bullet point? Glenn or Gertie, I think, are going to answer this question.
Yeah, I'm happy to lead, and Gertie will sweep up if I miss anything. Yeah, I mean, I think it's a really important area of our culture, actually, as an organisation. And there's some indications in the staff survey actually about how well we're doing on that, which is pretty good, but we can't be complacent. I mean, just to emphasise that the objectives are not meant to cover everything that we do. We will continue to support the wellbeing of staff and speak up, but we've tried to avoid it being a list of everything. But Gertie, did you want to add anything to that?
Yeah, I think what I'd probably add is there's obviously there's 3 main headings for workforce, which is about the culture, staff health and wellbeing, and then workforce strategy. I think for me, speak up is inherent in the first one, which is about empowering colleagues to contribute to passionate, compassionate care that improves the outcomes, because that is for me very much about raising safety. And I would say, as Glenn said, that this is by no means the list of activities that I or the team will focus on. So I would absolutely see speak up being in there, and I'd also echo the point around how positive our staff feel about speaking up, and that we listen to and take their concerns seriously, which once it's not under embargo, I'll be able to share more detail next month.
Thank you, Gertie. I think it is important for us to recognise we're on a journey on this. It is about the pursuit of excellence. I am aware that, for example, some colleagues on the BAME network feel that their voices still aren't being properly heard. So we just need to hear that, recognise it, and make sure we do something about it. The second question, please, Sarah.
Thanks, Russell. So this one's from David G, Public Governor for East Stratford and Borders. Reading up about the My Care programme, I note that is only available to owners of smartphones. Proportionately, the largest group used in healthcare is the elderly, who are also the group least likely to own a smartphone. More might have computer access like myself, but this is not available. I appreciate the need for secrecy, but I can carry out all my banking online, so why not my healthcare? Why is this large and growing group being totally excluded from the excellent facility? Glenn, are you answering this one? Thank you.
Yeah, I'm happy to. Yeah, I mean, just to be clear, the system is available on a web browser as well as on a smartphone, so it is available to people who do their home banking on their PC or Mac. I think one of the things that may have led to this conclusion is that there's a validation process when you set up that sends a text message back to a phone. So that's why we needed a phone number. But those text messages can be sent to landlines as well as to mobile. So it should work.
Okay, let's make sure we communicate that well enough to members of the public. Thank you, David, for the question. And the final question, Sarah?
So this one's from Mary Malloy, Public Governor for West Stratford and Borders. It's been noted at Clinical Governance Committee that the pharmacy department is significantly short of staff and carrying vacancies. As pharmacists are not classed as allied health professionals, their staffing issues are not included in the staffing reports the Chief Nursing Officer presents to the board or in the medical staffing report. I just wish to ensure the board is sighted of this issue, understand the pressure the pharmacy staff are working under and any implications of this to services. Also, has the head of pharmacy had the opportunity to talk to the board about this issue? I think Rebecca Moore is going to answer this question. Thank you.
Thanks, Sarah. So probably just to reassure the board and Mary that the pharmacy staffing vacancies are on their divisional risk register with some mitigations around those risks. That feeds into the corporate health and safety and the clinical governance committee, which then feeds up to board. So that's the line of sight really from the board's perspective. I'm happy to discuss with Fiona when she's back around whether that should be included in her staffing report. Traditionally, it's just been nursing in there because of our national requirement to report our staffing ratios and any breaches there. But I'm happy to pick that up with Fiona when she's back.
Okay, that's great. Thank you, Rebecca. That would be super. Thank you for all of those questions from members of the public. Our next meeting, and are there any other questions from members of the public? Please raise a digital hand if any members of the public want to ask a question. Okay, I can't see any hands being raised. So thank you very much, everyone, for joining us today. Our next board is again the first Wednesday of April. So look forward to seeing you then. Hope you all have given something up for Lent. I've given up chocolate, not to my own request, but to support my wife. I hope you're able to cope with the challenges of Lent. But in the meantime, take care, and board colleagues, I suggest we have a 10-minute break and get going again with the confidential board at 4:20. Thank you very much.